Hi everyone, my name is Bethany Sui. I'm an ICU nurse that works at Cal Regional Medical Center, and today I'm doing a presentation on decreasing ventilator-associated pneumonia through nursing education. Ventilator-associated pneumonia is a lung infection that develops in a person who is on a ventilator. This infection occurs when germs enter through the endotracheal tube and get into a patient's lungs. Of hospital patients who develop pneumonia, 47.9% of those patients develop ventilator-associated pneumonia. This is a very common hospital-acquired infection. This is some significance associated with ventilator-associated pneumonia and some statistics based off of the ventilator-associated pneumonia, also commonly referred to as VAP. Hospital-acquired pneumonia affects 27% of all critically ill patients, where 86% of hospital-acquired pneumonia is associated with mechanical ventilation. The mortality rate of VAP ranges between 27 and 76%, where Pseudomonas and Acetobacteria pneumonia is associated with higher mortality rates than those associated with other organisms. The estimated risk of VAP is 1.5% per day and decreases to less than 0.5% per day after the 14th day of mechanical ventilation. So what's the problem? The problem is there's a non-compliance and consistency in pneumonia prevention protocols. We can also say that there's a lack of consistency and compliance in infection protocols. This results in patient complications. Some complications include multi-drug resistant infections, increased antibiotic use, prolonged mechanical ventilation, increased ICU length of stay, and increased mortality. I chose to use the Johns Hopkins evidence-based practice model. I found that this model was very easy to understand, and I like that it was focused mainly on nursing. The first step is inquiry. What I got from this is, why is ventilator-associated pneumonia increasing among ICU patients? Then I came up with my practice question. How effective are educational interventions on improving compliance with VAP protocol among nurses? The evidence is the peer-reviewed articles that show that an educational intervention can increase compliance in protocols and decrease VAP. Education intervention can increase compliance in nursing policies. Then we go to best practice. This is the actual education that we would give to nurses working at the hospital. This would include hand hygiene, elevating head of bed, frequent mouth care, infection prevention such as standard droplet and airborne precautions. This is all associated with VAP prevention. The next thing we would do for practice improvements was we would recommend a pilot study to execute nursing education on a VAP protocol. And then we'd make adjustments to protocol as necessary to improve practice and patient outcomes. These are the articles that I found, the peer-reviewed articles that supported nursing education and increased compliance. The first article was done on hand hygiene, performance on the knowledge with standard precautions questionnaire, attitude with standard precautions scale, and compliance with standard precautions scale were significantly improved in the interventional group compared with the control group. The hand hygiene standard in the interventional group outperformed the control group. This was a randomized control trial. I feel like it had a lot of information, and the outcome was compliance with standard precautions. The second article was on hand hygiene. So this was a cohort study. It had a lot of information. It had a lot of participants in it, 396 nursing students. I found that a lot of the articles were geared toward nursing students, but I also found that was very educational. So the whole purpose of this article was promoting better hand hygiene practice among nursing students, and it was a multidisciplinary team which formed compromising infection control, physicians and nurses, and the nursing education team, and it measured hand hygiene compliance. The mean compliance of all nursing students in the post-intervention period was 64%, and then these results show a 50% greater likelihood to comply with hand hygiene compliance from the pre-intervention mean compliance. The third article was the effects of multi-method intervention on bedside report compliance and patient satisfaction. This was also a cohort study. It assesses nurses' knowledge of bedside report, pre and post education, and then it measured components of bedside compliance. Compliance of components of bedside shift report increased from 46 to 69%, and finally to 81% in periods 1 to 3, respectively. Compliance also increased in 6 months post-intervention, along with 12 of the 14 individualized measures. So these are the resources involved. So we would have to have our personnel involved. This would include our infection prevention coordinator, our nursing educator, and a respiratory therapist. Materials include a copy of the current VAP policy or infection prevention policy. The technology involved would be the ventilator, and we'd also need a lot of respiratory supplies, including ventilator circuits, an ET tube, and suction supplies. Other supplies include PPE, log sheet for attendance, and the department this would be done at would be the ICU, the trauma medical and surgical ICU, the intermediate care, and medical ICU too. The budget and timeline. So the time frame and cost, this would be over a 2-month period. We would start the proposal. The team hours would be approximately 45 employees. We do like 1 hour each month per employee. For education materials, I got $200, and then item supplies is $500. That's just an estimate. I'm not sure if it'd be more than $500, but and then of course we'd have to take into consideration the hourly pay for the RN project manager and the data collector hours. So I got subtotal for both month 1 and month 2, and then the total would be $8,120. So the barriers and strategies, some barriers I found would be the cost. A strategy to cost would be considering possible grant/volunteer hours for continuing education. We have a program at Cal Regional where you can advance your nursing practice through a clinical ladder, and one of these steps is through volunteer hours. You're not paid because it is a volunteer hour, so this could be a consideration as of course it costs to pay staff, but if they're volunteering, this would be a little bit cheaper. Lack of supplies, limit supply items as needed. Do not break original packaging so supply can be used in the future if not using hands-on method. Sometimes during education you just need the physical supply, but doesn't necessarily need to be opened, and the packaging can still be intact, and we don't have to actually account for using that item, and it can be returned to circulation. Workplace culture, I think, is a big one. Maintain positive environment and encourage suggestions for improvement. Another barrier would be time constraints. Allow additional time for data to be collected and organization of data. I think this would be a lot for a nurse to organize the data and collect the data. That's where most of the time would be spent. Lack of involvement. Provide a wide variety of days and times for staff to attend educational workshop. Implications for practice and conclusion. So what is the solution to increasing compliance and VAP protocol? It would be an educational nursing intervention. And what future research should be included? A pilot study of educational intervention and increased compliance in nursing practice. So all these things we talked about today will increase patient outcomes, which include individual clinical expertise, patient's value, patient's expectations, and the best available clinical evidence. And then these are my references.